This is a part 2 session of NEET SS 2023 recall, because there was a delay in getting up the appropriate questions with options, because if there are not appropriate questions and options constructed, and the entire concept and the meaning of the question will change. So, we will be doing part 2 and part 3. So, among the 3 books, almost 70 to 75% of questions have come from 28th edition of Bailey, and the rest of the question of say 20% comes from Subiston and 5% from Schwartz. I mean, as I go through the references, you will be able to see it. The features of hyperparathyroidism, young boy, next line of investigation. So, is it ultrasound neck, X-ray, bilateral radiation spine, PET scan or DEXA scan? So, the next line is the question here, is not the best investigation asked. Next line, the right answer is ultrasound neck. So, ultrasound neck can tell you what kind of pathology we are dealing with. Is it with the primary hyperparathyroidism? Is it primary, where the pathology is identified in the gland? Okay, identified in the gland, and the most common pathology is adenoma, and the second common pathology is hyperplasia, and the third common pathology is carcinoma, and it is rare. So, are we dealing with the primary? Yes, hyperparathyroidism. And secondary hyperparathyroidism because of a secondary cause or end organ resistance to parathormone, and untreated secondary becomes tertiary. So, primary is the most common and adenoma is the most common, and the most common gland involved is inferior parathyroid. Inferior parathyroid. So, the initial investigation will be an ultrasound, but the best investigation could be a direct exploration and visualization of surgeon directly, or if it would be investigation per se asked, it could be the PET scan or system may be SPECT scan. So, those scans will be able to identify abnormal parathyroid glands and pathology in parathyroid glands, especially adenomatous pathology. Understood? And so, this is what we are looking in this question. So, what it says? So, Bailey, 20th edition of Bailey, 877. Ultrasonography is a non-invasive, see that, non-invasive, inexpensive method of eye imaging parathyroid glands. Parathyroid adenomas are typically oval and elongated bi or multi-lobed hypoechoic structures. So, this is what is asked. Rarely adenoma may be cystic or heterogeneous in nature. Giant adenomas are described as those are over 3 cm in size are called giant adenomas. Ultrasonography is not associated with radiation exposure and has an advantage of being able to identify and facilitate biopsy of any concomitant thyroid pathology. However, ultrasonography is operator and lesion size and location dependent. Critically, ultrasonography may give you idea of pathology of the parathyroid gland. Understood? So, the most common complication can also be asked as a metastatic ectopic calcification like a renal calculus. So, it always says stone, bones, abdominal groans and psychic moans. Yes, the most common complication of hyperparathyroidism, hypercalcemia, and metastatic calcification of renal calculus is the most common type of complication that you could encounter in hyperparathyroidism. Okay. Subperiosteal erosion of corpus or resorption of corpus could be other X-ray finding that can be asked, and so rest all things are related to parathyroid, but the answer here is ultrasound. Okay. Tokyo guidelines is used for diagnosis of what? Acute cholecystitis, chronic cholecystitis, acute pancreatitis and chronic pancreatitis. So, the right answer for this is acute cholecystitis. Again, it is a very straightforward question and is taken from Bailey, 20th edition, page number 1244, very clearly says Tokyo consensus of guidelines of diagnostic of criteria for acute cholecystitis. So, in that even it is a mild, moderate and severe types are available. Okay. So, all these are the parameters which are there of local signs of inflammation, systemic signs of inflammation and imaging findings and suspected diagnosis and definitive diagnosis. So, all these are part of acute cholecystitis according to Tokyo classification. Understood? It's a straightforward question, and you can expect question again in the same area from for the upcoming NESS on 28th of this month. 12-year-old child comes to the OPD with a pain in the scrotum on examination. This is the keyword, blue dot is noted on the right side of the scrotum. What is the diagnosis? In case you feel that there is some changes in the question or to be corrected, you can definitely let me know so that we can correct the question and go for the answers. So, the right answer for this is a blue dot note on the right scrotum, that means right testicular appendage is involved. So, it is a testicular appendage's torsion, appendix of testis. We always say the appendigeal remnants of appendix of testis or hyoid of Morgagni, they undergoes torsion. The features are similar to that of a testicular torsion. So, it will mimic, the clinical features will typically mimic a testicular torsion. How you will be able to distinguish it? So, the investigation of choice comes to an important play here. So, it is a duplex Doppler. So, you should know that it is a duplex Doppler that will tell you what is the pathology. Is there a vascular compromise is there? Is the testicular artery is involved? And is there a gangrene setting into the testis? All that will be said. If it is not there, and there is a portion of what is a limited radiological signs which are like this, and could be only a torsion of appendages. And the other important differential diagnosis is epidermolysis. So, acute epidermolysis and the clinical finding, and always say that elevation and lifting of the testis and holding for some time. If there is a relief of pain, they always say it is an acute epidermolysis. If the pain is aggravating, then again it goes to the clinical feature of acute torsion of testis. So, the golden hour, they will ask you, golden hour, what is a golden hour? So, you have to do detorsion and fixing within 6 hours. There is a golden hour. If you miss that, equivocal signs and results could be expected from 6 to 12 hours, and anything after 12 hours, it should go for orchidectomy. Orchidectomy and fixation of opposite testis, and to prophylactically do orchidopexy on the opposite side. So, these are the key words that you should know. Investigation of choice, duplex Doppler, golden hour to do derotation. Yes, lateral sinus has to be lateral, derotation, lateral sinus has to be lateral, the testis has to be appropriate to the opposite side of the level of the testis, and lateral sinus is nothing but the groove between testis and epididymis. So, that has to be lateral with the proportion of level of testis comparable to the opposite normal testis. So, this is what about the derotation and fixing, derotation and fixing within 6 hours. Anything more than 6 to 12 hours is equivocal signs, equivocal, and more than 12 hours it could be go for gangrene. So, gangrene would set in. Okay, understood. So, Bailey and Love 20th edition, page number 1562, torsion of testicular appendages cannot always be distinguished certainly from testicular torsion, as we discussed. The most common structure tested is appendix of the testis, the hyoid of Morgagni, which sometimes is visible through a scrotal wall as a small dark spot. Small dark spot. If the diagnosis is made clinically, conservative management if possible, or in doubt, surgical exploration should be undertaken with the removal of twisted appendages. See, you always should have a minimal threshold in case of suspicion of a testicular torsion, that you should go for immediate testicular exploration. Even it is negative, nothing to worry about it, but because you have ruled out testicular torsion, that is the most important part of your treatment. If the torsion is there, you have treated, and if torsion is not there, at least you are sure that you have made an attempt, and going to be an epidermolysis or could be a torsion of the appendages of the testis, then you can even remove the appendages so the patient pain can be relieved. Chest injury with a suckling wound, best next step. So, that means it is sucking in air inside with every breath. So, that means a pneumothorax could accumulate and develop. So, what kind of treatment that the patient will require to have? Of course, an ICD will be drained, underwater still will be done, but what type of ICD drain has to be have? That is the most important. So, that is a temporary time-on procedure, time-honored procedure, but what is the ideal one here? Yes, what did you answer of A, B, C and D? The right answer for this is a 3-way flap closure. Okay, and this has also been discussed in the class. If and given clearly in 20th edition of Bailey and 371, your suckling chest wound is present, this should not be fully closed, but should be covered with a piece of plastic closed on 3 sides to form a one-way valve. 3 sides to form a one-way valve. Thereafter, an underwater chest drain should be inserted remote from the wound. No attempt should be made to close the sucking chest wound until controlled drainage has been achieved. In a case, a stable patient with an open pneumothorax is converted into an unstable patient with a tension pneumothorax. So, it is because that suckling wound can accumulate more atmospheric air and can create a tension pneumothorax. Understood? I hope you remember that the day I asked, immediately on that day, I asked how many questions, what about the number of questions asked in the 20th new edition of Bailey, because edition has changed. People said very less, but when I started working on the questions, we could see some of the lines, if you could see, there are with the direct references from 20th edition of Bailey. As I go, you will be able to look into it. A lady with a recurrent stones, UTI, high PTH and calcium levels, normal phosphorus and vitamin D diagnosis is. So, the complication is recurrent calculus, renal calculus. So, recurrent renal calculus, okay. So, there is a recurrent renal calculus, renal cal. So, high calcium and high PTH and phosphorus is normal, okay, and vitamin D levels are normal. What is your diagnosis? The diagnosis is very clearly primary hyperparathyroidism. The most common complication of primary hyperparathyroidism is renal calculus with high calcium and parathormone. Okay. So, primary hyperparathyroidism is a biochemical diagnosis. Only when the disease has been confirmed biochemically should location studies be undertaken. Positive imaging does not confirm the diagnosis and negative finding cannot rule it also. So, primary hyperparathyroidism is defined as elevated total or more specifically ionized calcium in the presence of inappropriately elevated and unsuppressed PTH. It is associated with a low serum phosphate in a setting of normal creatinine and vitamin D levels. Okay, here in the question it is given as normal phosphate, actually it should be hypophosphatemic metabolic acidosis with increased calcium and parathormone. That is a classical picture. Anyway, normal phosphate can also be there. 24-hour urinary excretion of calcium may be normal or elevated. Important to perform 24-hour urinary collection to rule out the presence of rare familial hypocalciuric hypercalcemia, FHH. Alkaline phosphatase may be elevated in patients who have concomitant bone disease. This is an important to recognize pre-operatively. The surgeon should anticipate significant post-operative hypocalcemia due to the development of hungry bone syndrome. It is a relative hypocalcemia. Those that in the serum can go into the vascular compartment. Okay, and from the bone it can go to the vascular compartment. So, that causes hungry bone syndrome. So, relative hypocalcemia. Understood? It is very, very clear. This case is clearly a case of a primary hyperparathyroidism. In secondary hyperparathyroidism, the level of the calcium will be low. So, it can be because of intestinal malabsorption or could be a chronic patient on a dialysis. So, all those could be the cause and it will stimulate, in turn stimulate the gland to produce more parathormone, where parathormone levels at later stage will be elevated, and uncontinued or untreated secondary becomes tertiary. Recurrent or persistent comes after the surgery. Once you do the surgery, after 6 weeks time, once initially all the levels of calcium comes down, parathormone level comes down to the normal level, and it recurs after 6 weeks, then it is called recurrent hyperparathyroidism. It is called recurrent after 6 weeks. Okay. And there is something called persistent hyperparathyroidism. Persistent hyperparathyroidism is a technical failure. That means surgery is improper removal or incomplete removal of parathyroid gland. So, where there is a sustained levels of parathormone and it maintains to some extent to high level of calcium. So, calcium does not fall immediately after surgery. It is called persistent hyperparathyroidism. So, treatment for persistent or recurrent hyperparathyroidism is remedial parathyroidectomy. Remedial parathyroidectomy. They can ask you, the video assisted parathyroidectomy was introduced by Paulo and Micoli. Okay. So, all this could be a potential question in the upcoming NESS. So, in an area, right, in the aspect of NESS general surgery component, you should just go through the grand test and also the previous year recall questions. Questions will be revolving around this area for general aspect. Okay, final bowel position after LAD procedure. Okay, it could be a LAD's band which can cause small rotation. There is a question about it. The right answer is small bowel onto the right and colon onto the left. Okay, after derotation. So, the exact picture is given in 20th edition of Bailey and 267. See, LAD procedure is there in Subiston and also in Schwartz. You see, the topic is common to all three books. But the close proximity to the reference where it is available, try to understand so that students can have some satisfaction that this is what I need to prepare, and in future also they should know then where I should expect the questions. LAD procedure, duodenum is placed onto the right, colon onto the left. The mesentery is broadened and the duodenum appears lie near the colon. Since the wound is small, the appendix may be removed. So, small intestine. So, duodenum is small intestine onto the right and colon onto the left. So, small bowel onto the right, colon onto the left. Is it okay? The very same question is there in a GT and also in image based in the app. You just go ahead and see, have a look at it. Yes. So, D2 gastrectomy, which node amongst the following is included? That means up to which level is included? That is the part of the question here. So, we know that. So, removal of N1 nodes is D1. Removal of N2 group of lymph nodes is D2. Removal of N3 group of lymph node is D3. N3 or you say N4. And the concept is, if no nodes are involved, N0, one level next to it should be removed. So, you do D1 for N0. For N1, you do D2. So, for N2 involvement, you go for D3, correct? So, this is the concept. One level ahead of the involved group has to be removed. Most commonly done procedure is D2. But the nodal status, that has to be removed. What is that to be removed? What is the answer? The right answer is splenic. So, removal of N2 group of lymph node is called D2 dissection. Okay. So, this is what it means. So, splenic nodes will be included up to splenic nodes. Understood? So, infradiaphragmatic esophageal hiatus, lower esophagus, supradiaphragmatic, all this for OG junction. These tumors all for OG junction or lower esophageal growth involving the OG junction of the cardia. So, you need to very clearly understand. So, the right answer is splenic. So, the blood supply level when the brain ischemia occurs. So, with less than what or up to what the brain goes for ischemia. Option A. So, where can I find this? So, 20th edition of Bailey, page number 360, intracranial pressure and cerebral blood flow. The brain depends on the continuous perfusion of oxygen and glucose delivery, hence survival. Normal cerebral blood flow is about 55 ml per minute for every 100 grams of brain tissue. Ischemia results when the rate drops below 20 ml per minute and even lower levels which result in infarction unless promptly corrected. See, when ICP will be raised. See, you know Monro-Skelly doctrine. What is Monro-Skelly doctrine? See, it's a rigid structure. Cranium is a rigid structure. There are three components. One is the blood, the other is CSF, other is the brain parenchyma. Any adjustment that has to happen to maintain the ICP normal, the compensation has to happen in any of the three components. Understood? And that is the cause of SOL, space occupying lesion and effects. If the balance cannot happen between blood, CSF and the brain parenchyma, then the complication occurs. Understood? So, if there is a tumor, suppose frontal lobe tumor, any tumor, then it becomes a SOL, then it increases the intracranial pressure and thereby causing features of SOL. Or else going to be an obstruction, an aqueduct of Sylvius. Then what happens? Obstructive hydrocephalus happens and CSO pressure rises, in turn ICP rises. Or going to be in a trauma, an extradural hematoma where middle meningeal arteries are involved and ruptured, or going to be dural venous sinus rupture in case of a subdural hematoma or a perineurial rupture in subarachnoid hemorrhage where the bleeding has happened, or it can be one of the most common causes, hypertensive bleeds, where it happens in the internal capsule of the putamen and this is one of the most common cause. Also the bleeding can cause ICP increase. So, all these are going to be the primary cause of the etiology and increase in ICP. Compensation will try to develop like a midline shift, herniation, all this happens. In case it goes beyond a level, all this will lead into a complication and acute brainstem herniation and complication of death. One of the earliest to compensate is the subfalcine herniation, where from one side of the cerebral hemisphere, most of the opposite side, or where the midbrain herniates and compressing the uncus and the oculomotor nerve, they call uncal herniation. Third is about the tonsillar, cerebral tonsillar herniation, and through foramen of magnum. So, all this are and transtentorial herniation, and that's the uncal herniation. So, the types of herniation that you will see in case of ICPs. Which type of choledochal cyst resembles an accessory GB? Your response will be utmost respected and will be very happy. The type of choledochal cyst which resembles an accessory GB, gallbladder. The right answer is type 2. Answer is B. See, type 1 is a fusiform or cystic dilatation of an extrahepatic biliary duct, where type 2 is a saccular diverticulum of the extrahepatic biliary tree. That is the reason it looks like accessory GB. Type 3 is a choledochal seal. Type 4A Yes, it is a multiple intrahepatic and extrahepatic cyst, where type 4B is only multiple extrahepatic cyst and type 5 is Coriolis disease, multiple intrahepatic cyst. The most common type is type 1 and the least common type is type 5. And the treatment of choice for type 5 is hepatic transplant. Understood? Hepatic transplant. So, because this all will be asked. Type 3, ERCP and puncture. ERCP and puncture of the cyst. Rest of all, excision of the cyst and biliary reconstruction. So, this is about a gross feature of choledochal cyst, and choledochal cyst, the type of classification is called Todani classification. I can ask you the name. What is the name of the classification? Todani classification. Understood? So, the right answer for this question will be B. 15-year-old child with a mild PAH and ECG normal, MS with no calcification. That means valves are clear and valve is pliable, treatment of choice. So, mitral stenosis, have mild PAH, severe PAH, then and it can lead on to the failure, and where the outcome may not be as good as done at this stage of life. And ECG looks normal. So, that means no chamber hypertrophy has happened so far. Understood? And also no AF, atrial fibrillation or arrhythmia have set in as a complication of MS. Understood? So, what will be the ideal? And see, look at the age also. And only MS, not associated with MR. So, that means the ideal treatment would be, and this question also been discussed in the class at length. The answer is percutaneous balloon valvuloplasty. That means, like a Scheldinger technique, you take a femoral artery or a radial artery route and try to go onto the side of aorta and to across the LV and then across the mitral valve. So, across the mitral valve, okay. So, LA, LV. So, this will be the aorta. So, this is the valve. So, it is not tight MS, suppose. This is the chamber, this is the LV and interventricular septum that gives rise to this aorta. And so, this is the anterior leaflet AML. So, PML. This is also a question. Which valve will act as a barrier between the inflow tract? Inflow tract is what? Inflow tract is left atrium to left ventricle. Outflow tract is left ventricle to aorta. So, this is the inflow tract. So, this is the inflow tract and this is the outflow tract, which act as a guardian or barrier between the inflow tract and the outflow tract. This is called the anterior mitral valve and the anterior mitral leaflet. Now, it's a tight MS. So, what we should do is, this technique is where you get a guide wire coming across the aorta, across the aortic valve, then coming across into the LA. So, you will keep the guide wire across here, and what you will do is, you will put in a balloon and you will open up the valve. So, it gets opened up. So, it is called balloon valvuloplasty. This is one technique. The other technique is where you can come through the RA, right atrium, and transeptally you can make a puncture and also you can come inside. Or there could be a persistent foramen ovale, okay, and you can come through that, and also you can open up the mitral valve. So, that it is called balloon valvuloplasty. Understood? As you open up the stenotic vessel, similarly you just put across the guide wire and put a balloon and you can just inflate it. Sudden onset of headache and nuchal rigidity in a woman without a history of hypertension. This is the most common. This is an important question here. So, that we call it as the worst headache a patient, somebody says the worst headache in a patient's life could experience. If the nuchal rigidity, see, any headache will not have a nuchal rigidity. So, nuchal rigidity and it's like thunderclap. Somebody is saying it's a thunderclap headache. That means it's what? Subarachnoid hemorrhage. What is it called? Subarachnoid hemorrhage. Understood? So, typical presentation of SAH includes the thunderclap. See, again, Bailey 20th edition 709, which is both sudden and severe onset. In patient's normal experience, some patients describe as prodromal headache preceding the event, particularly resulting in aneurysm of growth or subclinical bleeds. The sudden onset occurs most commonly not exclusively during the exertion and may associate with seizures in 10%, unresponsive in 50%, vomiting in 70%. Sometimes it's difficult to establish whether SAH has caused a fall or a fall with a head injury is responsible for an SAH. Approximately 1/3 of SAH is incorrectly diagnosed in initial presentation. Patient with high risk has coming to early complication, especially rebleed. Understand, the most common cause is subarachnoid hemorrhage. The question will be asked. The most common cause is trauma. And there could be an underlying berry-aneurysm, no doubt. It could be one of the underlying berry-aneurysm. Could be there, and the perpetuating cause or precipitating cause could have been a fall, head injury. So, thunderclap headache. They will also ask you what is the classification or prognostic scoring scale for subarachnoid hemorrhage. It is called Hunt and Hess. Hunt and Hess classification, where it ranges score 0 from asymptomatic to 5 is comatose. Okay. So, 1 will be mild headache, 2 will be moderate headache, 3 will be severe headache with stuporous gait, and 4 will be focal neurological deficit. Focal neurological deficit, I will repeat. Hunt and Hess is one of the most important questions you can expect in NESS. The NESS question, I am just telling you. From there, I am just telling you this, because it is an orientation today for NESS as well. So, what they can ask you, what is the prognostic scoring scale for subarachnoid hemorrhage? The answer is Hunt and Hess. 0 is asymptomatic, 5 is comatose, 1 is mild headache, 2 is moderate headache, 3 is severe headache, or it could be a stuporous gait, and 4 is a focal or significant focal neurological deficit. So, focal neurological deficit would be significant, and 5 is comatose. Understood? And the investigation of choice is digital subtraction MRA. Digital subtraction MRA, you should know whether there is a neck for aneurysm is there or not. Yes, whether it's a neck like this, okay, or no neck. If there is no neck, then you should go for coil embolization. What you will go for? Coil embolization. If there is a neck, you will go for clipping of the neck. Both you use titanium, coil or clip. Understood? So, these are the possible questions that could be asked. Yes. EDH. The EDH, the most common site of injury is tedion, thinnest portion of the skull bone, and the middle meningeal vessels could be an injury, ruptured, biconvex lenticular shaped hematoma, lucid interval can be present, has good prognosis compared to the rest of all the other hemorrhages in the brain. Okay, child with a brain tumor, histopathological examination says pilocytic astrocytoma. Test for genetic mutation. We had a lengthy discussion on this when I took a neurosurgery. Right answer is ATRX. See that? Bailey. The page number is 716, 48.24. So, astrocytoma, oligodendroglioma, oligodendrocytoma, glioblastoma. What question is asked? Astrocytoma. Okay. When you see mutation, yes, when you see the mutation, IDH mutant, IDH wild type, ATRX loss or TP53 mutation causes diffuse astrocytoma. Yes, diffuse astrocytoma. 1p by 19q co-deletion, oligodendroglioma, an IDH mutant 1p 19q co-deleted. So, among the list, the best answer available is ATRX, that is related to this. Rest all even not even related even to keep it up in the argument. So, it is very, very clear. Gene involved in familial gastric cancer, this is also discussed. Very, very simple, straightforward, factual question. Anyway, you will be able to answer. What is the answer? Gene involved in familial gastric cancer. The right answer is CDH1 gene. Yes, very, very clearly said. Bailey and Love, 20th edition, page number 1220. Gastric cancer associated with several rare inherited disorders. Patients with hereditary diffuse gastric cancer resulting from a gene mutation, a cell addition molecule. E-cathepsin, CDH1 gene, have seen in 60 to 70% of patients with lifetime incidence of developing gastric cancer. High Gleason score infers what? Recurrence, metastasis, poorly differentiated, well differentiated. So, Gleason score says is mild, moderate or poorly differentiated. It's poorly differentiated. High Gleason score is poorly differentiated. So, the prostate cancer is diagnosed histologically, and it is given in page number 2094 in 20th edition of Billy. Prostate cancer is diagnosed histologically by Gleason grading system, which evaluates the level of abnormality of the patient in a pattern of glandular architecture of the prostate in comparison to normal. The grading system is based on a scale of 1 to 5, with 1 being most well differentiated and 5 being least well differentiated. In modern PSA based screening era, prostate cancers having a Gleason of minimum 3 with a sum of 6 or greater, and majority are newly diagnosed cancer have Gleason 3 plus 3. Okay. Anyway, higher score is poorly differentiated. Drug having action against HER2 new and EGFR2 tyrosine kinase inhibitor. That means dual blocker. The question in other words has been asked, which is a dual blocker here. The answer is very, very clear and simple. The dual blocker that is available in use of breast cancer is lapatinib. Okay. So, when you see lapatinib, inhibits tyrosine kinase associated with EGFR and HER2, even for type of breast cancer. Onset of which type indicates high risk mortality in aortic stenosis. It is not only aortic stenosis. If this question is asked for even mitral stenosis or even any other cardiac disease, yes, one of the most symptoms which indicate high risk. When you plan for a surgery, if it is there, then it is high risk. See, syncope, palpitation, angina are symptoms. Heart failure is a complication. So, if heart failure sets in, of course, there is increased mortality. Understood? So, that is a very clear answer. Okay. So, aortic stenosis, Subiston, 21st edition, page number 1729. Patients with AS will typically be asymptomatic for an extended time. The onset of symptoms occurs when the Wolff orifice decreases approximately 1 centimeter square. This is a critical stenosis. Okay. The classical symptoms of AS are angina, pre-syncope associated with dyspnea, and whereas angina is presenting symptom in almost 35% of patients, syncope is relatively a sporadic event. Although heart failure typically appears late in the course of AS. Dyspnea and other heart failure symptoms precipitating angina in 50% of patients. So, it is a late complication, and if it sets in, and definitely the patient will have a poor outcome following treatment, especially surgery. If heart failure develops, the apical impulse may become laterally displaced, characteristic of upstroke of AS with a short rate of rise, slow rate of rise and reduced peak. It is called pulsus parvus et tardus. You would have learnt in MBBS days. Okay. So, heart failure is an answer that you can ask a universal answer for any cardiac surgical cases. Post-hepatic IVC bleed, best managed way. So, all Pringle and all for pre-hepatic. Post-hepatic will be a complete vascular isolation. So, if you go through this algorithm which is there in the Subiston 21st edition page number 418. So, bleeding from hepatic trauma, minor, it will settle automatically by itself with some minimal treatment. Major bleed, pre-hepatic packing, resuscitate, and if bleeding is controlled, damage control, laparotomy, consider angioembolization, ICU for resuscitation. Bleeding uncontrolled, then you can use a Pringle maneuver. And Pringle maneuver, bleeding is controlled and selective vessel ligation and momental pack. Bleeding control, consider angiography. Uncontrolled, consider selective hepatic artery ligation. Okay. After Pringle maneuver also, the bleeding is uncontrolled, you have pre-hepatic packing resuscitation. Okay. If the bleeding is controlled, then go for ICU for resuscitation. If the bleeding is uncontrolled, so you have done a Pringle, again uncontrolled, pre-hepatic packing resuscitation, uncontrolled, then you go for consider vascular isolation with shunting procedure. Okay. So, this is what is the question that is asked. Most common complication of total thyroidectomy. What is answer? The right answer is hypocalcemia. So, improper hemostasis might cause hemorrhage, no bleeding. Hypoparathyroidism, Subiston 21st edition, page number 915. Hypoparathyroidism is the most common complication of thyroid surgery. Is it okay? It's a very, very basic point. And that is a cause of hypocalcemia. Okay. And if there is a symptomatic hypocalcemia following surgery, see, Hypocalcemia because of hypoparathyroidism results from 2 to 5th postoperative day, POD. They can ask you, which postoperative day you will expect hypocalcemia because of hypoparathyroidism? The right answer is 2 to 5 days postoperative day. If they ask you a hypocalcemia in the immediate postoperative period, the immediate postoperative period with hypocalcemia, it is called hungry bone syndrome, first day. First day hypocalcemia, it is hungry bone syndrome. It is 2 to 5 days hypocalcemia because of parathyroid insufficiency. Understood? Because would have been a displacement of calcium after the thyroid is removed, pathology is removed, there could be displacement of calcium from bone to the vessel. So, relative hypocalcemia might occur. So, this you should know. Okay. So, in case of hyperthyroidism, what could have happened is shift of calcium could have happened. So, after the correction, the calcium can shift to wherever it has been lost. Suppose it has been lost from the bone, it can go back to the bone. And in case of hungry bone syndrome, it goes back to the bone. So, that there is a drop in calcium in the vasculature. So, it is called relative hypocalcemia. When you measure the total calcium, it will be normal. So, what is the treatment for hypocalcemia in case of symptomatic hypocalcemia? So, we all know that 10 ml, 10% over 10 minutes of IV calcium gluconate has to be infused, then followed by oral calcium / vitamin D supplementation. So, acute stage 1 and then maintenance is by stage 2. Is it okay? Hemorrhage, the most common cause, they can ask you, respiratory distress could be the other question, respiratory distress. The most common cause of respiratory distress is laryngeal edema. The most common cause of laryngeal edema is tension hematoma. The most common cause of tension hematoma is slippage of ligature from superior thyroid artery pedicle. Say, most common cause of respiratory distress is laryngeal edema. The most common cause of laryngeal edema is tension hematoma. The most common cause of tension hematoma is slippage of ligature from the superior thyroid artery pedicle. And what you should do? You should relieve the skin sutures. In the ward, shift the patient to OT, intubate, steroid and ligate the bleeding vessel. If suppose superior thyroid artery is not the problem, then next you should expect the middle thyroid vein. What you should expect? Middle thyroid vein. So, D option is say tracheomalacia, I will add here. Tracheomalacia. That happens whenever you remove a large multinodular goiter. Tracheomalacia is seen whenever a large MNG is removed, where you remove the patient from the thyroid. That is what we say when tracheomalacia happens. This question word to word was discussed. 2 times I discussed the question. Answer is rhomboid flap. So, Limburg flap is a rhomboid flap. Rhomboid Limburg flap. In this technique, the skin flap is precisely designed opposing 60 and 120 angles, 120 degree angles at the corners of the rhomboid design immediately adjacent to the defect. So, you can see the shape. Now, when I go back to the question, we ask something which is common. The most common cause of thyroid surgery is hypoparathyroidism. Then you take for any surgery, bleeding is a common complication. See, those are very specific questions which are asked. See, when I say the most common cause of respiratory distress is laryngeal edema, the most common cause of laryngeal edema is tension hematoma, the most common cause of tension hematoma, slippage or ligation of superior thyroid artery pedicle, number 1 cause, number 2 could be middle thyroid vein, number 2 cause, and what you need to do is the patient will be in respiratory distress, remove the skin sutures to relieve the tension and shift the patient to the OT. By the time you try to intubate in the ward, if not at least in the OT, and give steroids. Now, here the type of thyroid surgery is not asked. Here the question asked is total only in the question itself. Is the question different? Is the same question or different question? They didn't ask you any thyroid surgery. Here total thyroidectomy is very clearly asked. Hypocalcemia will not occur in hemithyroidectomy because opposite parathyroids are normal. No, the question is very clear. Then why are you getting confused? So, Limburg is rhomboid flap. Factual question. Indicative of active bleeding in splenic trauma. It's a radiological question. And this is also been a question of discussion and very, very clear. Hyperattenuating foci in spleen. Okay, hyperattenuating foci in spleen, and that will be a very clear indication of splenic trauma. And this picture was taken from Schwartz 11th edition, page number 204. Surgery not done in chronic pancreatitis. We all know that phrase dual virginal or surgery for chronic pancreatitis. So, it could be of exclusion also. This is question I have taken because same is available in Bailey and Schwartz also, I mean Subston also. For the feel of people who have read Schwartz, they should also know this information is available in Schwartz. So, Duval's caudal pancreatic jejunostomy, you can see the procedure here self-explanatory. Number 2 is the Burgess procedure. Okay. So, it is very clear that the duodenum preserving pancreatic head resection. Yes, it is called Burgess procedure. Understood? And I am showing you the phrase procedure also. I am showing you the phrase procedure. So, local resection of pancreatic head with a longitudinal pancreatic jejunostomy. Lay opening of the duct and do a longitudinal pancreatic jejunostomy. Post laparotomy, concern for IAP. How to measure IAP? Intra-abdominal pressure. So, bladder pressure monitoring. How do you do that? See, what you should do is very simple bedside technique I will teach you. The urinary catheter is there. You have to remove the connector, and so that from the bag. And what you do is you just take it up. Okay, if the patient is like this. Okay, the patient is lying down like this. Now, so you will take the fold is up. The patient lying, head end is here. Chest. Okay, representation, diagrammatic representation. Now, what you do is you insert IV set. You put an IV set inside. Okay, and then what you do is take a scale. And see what is the rise of urine in the IV, because it is transparent, right? Sterile one, put it sterile one, and raise. You measure what is the centimeter it raises. So, with that you will be able to calculate. With that you will be able to calculate what pressure it is. Or there are specific catheters which can be inserted into the Foley's of the bladder, and then you can put into the pressure monitoring system. It can give you the accurate pressure also. That is also is there. Understood? So, that is a technique which has been put up here in the explanation. Gunshot stab, gunshot/stab, neck injury zone 2 centimeter carotid disrupted management. So, when the carotid disrupted, you have to reconstruct it. So, either you can't do a ligation or you can't do anything, you can't do a repair. So, you have to do what you need to do? Venous interposition graft. And the arterial defects are 1 or 2 centimeter, often can be bridged by mobilizing several ends of the vessel after the small, ligating the small branches. And the venous interposition graft is an end-to-end anastomosis, cannot be accomplished without a tension despite mobilization. So, for vessels less than 6 mm in diameter, internal carotid, branchial or superficial femoral popliteal, an autologous great saphenous vein graft from the contralateral groin should be used, because PTFE grafts are for less than 6 mm, have a prohibitive rate of thrombosis. So, you will use a great saphenous vein. So, venous interposition graft will be the right answer here, because the disruption is more than 2 centimeter, 2 centimeter. So, if it is 1 to 2, you can try to mobilize the ends. It is 2 centimeter, then you have to put interposition graft. So, arterial defects of 1 to 2 centimeter can often be bridged by mobilizing the severed ends of the vessel. But here you can't do it, because it will give away. So, that is the reason why you should put, the best will be to put a great saphenous vein, natural graft on the opposite leg. Yes or no? They can ask you the best graft of choice for infrainguinal bypasses. They can ask you this question. Suppose the graft, they can ask you suprainguinal bypass. They can ask you infrainguinal bypass. For suprainguinal bypass, Dacron you can use. Infrainguinal bypass, the best choice is saphenous vein graft. The next best will be PTFE. Understood? And saphenous vein graft can be used in situ graft, in situ or reverse. Understood? Dacron could be 2 types, knitted Dacron and woven Dacron. Knitted, you should use pre-clotting technique, because there are porosity to be arrested. Woven, it's watertight. Dacron is a textile synthetic polyester. Textile synthetic polyester. PTFE is polytetrafluoroethylene. So, I will repeat this. Graft of choice, supraangular bypass, Dacron will be used. Dacron are two types, knitted or woven. And knitted, if you use, you should pre-clot and use the graft. And infraangular bypass, saphenous vein graft is the choice best. You can use reverse or in situ. In situ, if you use, you should break all the valves. So, you should use valvulotome to break the valves, so that valve does not disturb the flow of the blood. And PTFE is polytetrafluoroethylene. The best graft across the joint, they will ask you. Suppose one of the most important joint is knee joint. The answer will be saphenous vein. In case you want to use PTFE, you will use ringed PTFE. Ringed PTFE grafts will be used across the joints. In case you want to go across the joint, best will be saphenous vein. In case saphenous vein is not available, not possible, then use ringed PTFE. Gunshot with through and through to colon and next management. Any gunshot wound, any penetrating wound into the colon, diversion only. Resection anastomosis is never a choice. Understand that. Resection anastomosis always happens only in a prepared bowel, single stage. In case of injuries like this, you should exteriorize. Because there could be a leak, there could be a contamination, you should give a wash and you should exteriorize. Diverting stoma is the best answer. Criteria for ostomy. Criteria for use of an ostomy. High velocity bullet wounds, gunshot, shotgun wounds, explosive blast, crush injury. They are related to the part of our questions. This is for reference, but even without reference, I am telling you. Because any penetrating injury, how will you do resection? There is no scope of resection at all. What do you want to resect? See, you suppose okay. Now, suppose you say there is a gunshot wound here. What do you want to resect here? You can do only a debridement of the anterior abdominal wall. And what resection you are going to do here? You suppose there is a tumor or pathology, you can resect. A devitalized tissue, only a debridement is required. That is not resection. The ends can be resected, that is not resection. You will never do that. In case of a gunshot injury, this part has to come out. This part, you just need to freshen these areas, remove the gunshot wounds and just bring it, okay. We are opening up the anterior wall and where it will open up the proximal and distal. It will open up, that is it. You need to exteriorize into the anterior abdominal wall, that is what you need to do. You will never do resection or primary anastomosis in a gunshot wound or even a penetrating wound also, never. So, what you will do is, in case you feel that it is extensively damaged, then what you do is, this area you can remove like this. In case you are going to go all through the layers, both the anterior and the posterior wall, then what you will do, you will bring the anterior end as a proximal colostomy and the distal end, either you can use a Hartmann's, yes, or you can create as a mucous fistula. This is like a double barrel colostomy, that what you do for volvulus. Okay. Either separate like a mucous fistula, if they are together, it is called what procedure? Double barrel colostomy. Understood or not? And after 6 weeks, you will do a proximal distal anastomosis and push it inside. Is it okay? Because by this time, there would be a spillage and contamination into the peritoneal cavity. You have to give a good wash. You need to bring out the patient with the sepsis. Here, the idea is not to do a repair. Here is to save the patient from sepsis. That is very, very important. Cleft lip is due to, this is a very primary question, a factual question. So, failure of fusion of median nasal and maxillary process. So, people who have, this is available in again in Bailey and Subsistent, but for people to show some percentage of questions from Schwartz, I am making it. Embryology of lip and palate, the primary palate given in 11th edition of Schwartz, page number 983, which includes the nostrils, upper lip, alveolus and hard palate anterior to the incisive foramen, forms from the fusion between the medial, nasal and maxillary prominence during week 4 through 7 of gestation. Development of hard palate posterior to the incisive foramen and soft palate, which are collectively called the secondary palate, occurs during weeks